Okay, good afternoon, folks. Welcome to this demonstration box. I don't actually have any toys to demonstrate today, so we're going to treat this more like a small group interactive talk. My name's Niall Ferguson from the University of Toronto. Massimo Antonelli is, I think, busy looking after the Pope and can't be here in this moment. So for those who just came up showed up to see Massimo, I won't be offended if anybody wants to leave. And what we're supposed to talk about today is, I think, an increasingly important problem about monitoring efforts during spontaneous breathing in patients receiving mechanical ventilation. So, as I said, I've got some slides. I'm going to take you through some of the background of the problem, and then we're going to spend the bulk of the time talking about actually how to do this at the bedside. Okay, and as I said, feel free to interrupt and ask questions as we go along. Nothing really particularly relevant for this talk. So, when we spend a lot of time thinking about ventilator-induced lung injury, and there's no argument that the way, as we heard, if some of you were in the mechanical ventilation session upstairs just recently, there's no argument that the way in which we use the ventilator definitely impacts outcomes for patients, and this is true whether you're a true believer in 6 mils per kilogram or just think that 12 mils per kilogram is bad. The unifying conclusion here is that the way we use the ventilator definitely impacts outcomes. But remember that the ARDS trial, which was done in the late 90s and used volume cycled assist control ventilation for everybody, was done at a time when these are observational data from Andres Esteban's international studies of mechanical ventilation. In the top up there, which it doesn't need to be big for you to get the message, this is the mode of ventilation that every patient was on every day for the first 28 days. And in 1998, up here in the corner, everybody was on volume cycled assist control ventilation for their entire duration of ventilation. And that was true. That's what happened in the ARDS study too. Everybody was on assist control until such time that they really had met really minimal settings and could tolerate very low levels of pressure support, essentially just to facilitate spontaneous breathing trials. But our world has changed, and these are data that are 15 years old already, and they already show you that that still on day one in 2010. Assist control was still most common. I suspect if we repeated this study today, it might even be more common to see pressure support being number one, but certainly by the second week of mechanical ventilation, pressure support and spontaneous breathing is the dominant force here. So it's a practical issue for us as clinicians. We need to know how to deal with spontaneous breathing. And there may be this inconvenient truth of patient self-inflicted lung injury. Some people don't like that term because it sounds like we're blaming the patient for making things worse for themselves. But it's really just the idea here that force is generated by the patient, creates pressure differences that are negative pressure compared with the positive pressure that we give the ventilator, and they may be distributed differently, and they may be dynamic within the breath differently than a positive pressure breath, but there's still significant distending pressure that's generated by the patient, and that may well worsen ongoing lung injury, that especially early on in the course of the disease. Now, is this a real thing, or is this just something that Laurent Bouchard and Art Slutsky and Antonio Pezzenti dreamed up? Well, this is an old animal experiment, but it proves, at least on a proof of concept, that we should maybe be thinking about ventilation-induced lung injury as opposed to ventilator-induced lung injury. In this experiment, they injected salicylate into the foramen magnum of sheep, and that made them hyperventilate a lot. But there are no ventilators in this experiment. The sheep were just breathing on their own. And the ones that hyperventilate a lot had a lot of ARDS in their lungs when they did postmortem studies. So this proves the fact that you certainly can create ARDS by having spontaneous breathing. How relevant it is to our patients, that's still an ongoing debate. This is also an interesting study from Takeshi Yoshida when he was in Sao Paulo working with Marcelo Amato, and showing this concept of Pendeluft. German speakers will know this literally means swinging air. That when pigs in this instance with lung disease breathe spontaneously, the whole tidal volume doesn't get equally distributed to the lung at the same time. In fact, all the tidal volume goes to one area of the lung first, and then to another area of the lung second. So you functionally, from an alveolar perspective, you might be receiving twice as much tidal volume as you think you're giving. Another Takeshi Yoshida study showing that spontaneous breathing maybe depends on how significantly ill the patient is, how severe the lung injury is. In this experiment, they took rabbits and gave them mild lung injury just with saline lavage, or they gave them severe lung injury with saline lavage plus some injurious mechanical ventilation. And the results are quite striking that when there's mild injury and spontaneous breathing is good. When there was severe injury, spontaneous breathing led to much worse histological results here. So it's not a yes, spontaneous breathing is good or yes, spontaneous breathing is bad. As usual as most things in medicine, it depends, right? And so this really means we need to personalize our approach with these patients. Now, we spent 30 years thinking about ventilator-induced lung injury. In the last 10 years, we started to think more and more about diaphragm-induced, ventilator-induced diaphragm dysfunction. Okay? And recognizing that the way we use the way patients are on the ventilator impacts their diaphragm structure and function. In this pretty simple study, all we did was just measure and record diaphragm ultrasound every day over the course of time, as well as looking, and so we could tell how thick the diaphragm was, and we could also tell how much diaphragm activity was happening by looking at the thickening function, the thickening fraction of the diaphragm. Just as if, as when you flex your bicep, it thickens and increases in size. Same with the diaphragm in the zone of apposition. As you breathe in, the diaphragm contracts, and the diaphragm on M mode gets visibly thicker, and you can measure that, and that thickening fraction is related to the amount of effort and work that the patient is doing. And so in a series of patients who are just being treated by their clinicians, we didn't manipulate the ventilator settings in this at all. You can see a few things. Let me see if I can get this pointer to work. No. Okay, the pointer doesn't really work. So I'll point. At start, so in some patients, there was a rapid reduction in diaphragm thickness, and that was related to how much work the diaphragm was doing. So the diaphragm is one of these muscles that's designed never to rest, and when it does rest, we see a rapid reduction in thickness of the diaphragm, which we think is related to atrophy. In patients who were making relatively normal amounts of efforts, thickening fractions in the 25 to 40% range, which is around normal, no major change in diaphragm thickness over time. In those who were working very hard, we actually sort of somewhat unexpectedly saw an increase in diaphragm thickness, which was actually accompanied by a reduction in function. So we think this is not natural or good hypertrophy, but rather edema and other factors that may have led to muscle dysfunction. Because as we extended this out to a larger number of patients, you can see here that on any given day of mechanical ventilation, you were more likely to be extubated if your diaphragm was closer to its original thickness. And if you had significant atrophy or you had a major increase in the thickness of your diaphragm, that was the hazard ratio for being liberated from the ventilator was lower in this U-shaped curve here. So all that to say, we want to find the sort of sweet spot for spontaneous breathing for lung protective ventilation And maybe as a secondary consideration, and trying to get patients off the ventilator faster, also trying to keep a relatively normal amount of effort to help protect the diaphragm. And this is just this is another observational study that's been recently published, which shows that a few things. One is that a lot of patients spend a lot of time not doing any breathing, even though we're more aware of it. This is electrical activity of the diaphragm measured every day, and the blue you can see here is blue and light blue is absent to nearly absent electrical activity. So in about 2/3 of the patients on day one, and even extending further out, is still a lot of inactivity happening. There's a lot of dyssynchrony that happens as well, and that's spontaneous breathing. Obviously, is one of the prices that we have to pay for that is dealing with synchrony or dyssynchrony with the ventilator. It's very easy to have the patient in sync with the ventilator when you're on neuromuscular blockade and in an assist control ventilation setting. I'm going to skip over this part, actually. And one other factor to think about is that when we're having spontaneous breathing, that also is generating negative pressures in the chest, which may have impacts on the cardiovascular system and may draw edema into may paradoxically worsen interstitial edema as well. So there's lots of stuff going on, and this is a nice, if you want to read about sort of a nice summary of what we think about both lung and diaphragm protection together. It's a few years old now, but a paper in the Blue Journal from a pre-COVID symposium on this topic. So we have lots of questions remaining, obviously. When should we allow spontaneous breathing? How much to allow? And then if we're allowing it and measuring it, is making things normal the right answer? Because obviously that's not always the right answer in critical care. And I tried to summarize the pros and cons here by saying, okay, on one hand, spontaneous breathing is good because we may prevent diaphragm myotrauma. We might improve hemodynamics, improve venous return. You may need less sedation and its associated complications. And as a clinician, you feel good. Okay, I'm moving my patient forward towards eventual liberation from the ventilator. But on the other hand, there may be downsides. You might have more direct overdistension injury of the lung. You have this pendulift injury that we talked about, increased lung perfusion from increasing dynamics, lots of dyssynchrony, which may either be double triggering or post-inspiratory loading, and when you have expiratory muscle activity, you may lead to decreases in end-expiratory lung volume. And which side of these pros and cons you land on probably are affected by how severe the ARDS is, how small your baby lung is, how high is the patient's drive if you start letting them breathe spontaneously, and what ventilator settings do you have the patient on. So how do we measure effort? So let's try to make this more interactive. Who ever thinks about trying to quantify patients' efforts during mechanical ventilation in your daily practice? Okay, I would say it's a minority, but not zero. That's good. Great. And so the question is, great, how do we do that? Because I'll tell you, 20 years ago, we used to do that mostly just by looking at from the end of the bed and saying, well, that patient's working hard, right? And that still works in some patients. You can see that it's very obvious. But I think that having tried to do this more systematically, you end up seeing quite a few patients who can be making quite large efforts without really looking like they're in distress. And so if we want to actually quantify how much efforts we're doing, here are 6 different ways that we might be able to do this. Right? The first is, and probably the gold standard, would still be to insert an esophageal balloon and using the swings in esophageal pressure as surrogates for pleural pressure, directly quantify how much efforts are making. Who uses esophageal balloons regularly? Few? Okay, some. I mean, we do sometimes, but certainly not in every patient. Practically because they're pain to use if the ventilator that the patient's on doesn't have a port for you to directly connect the thing to. Trying to look at the hemodynamics monitor and look at the ventilator at the same time, and they're in different units and they're not synchronized. So I find that really that doesn't work. So if when I do want to use an esophageal balloon, I bring in the ventilator that we can connect the patient to connect the esophageal balloon directly to, and then with a little bit of practice, it's actually not as complicated as many people would have you think. But that's our gold standard. It's not going to be available even when you do them. You're not going to do them in every single patient. Let me just see if I have. Yes, here we go. So this is a nice review. I'll just show you the reference here. In intensive care medicine a few years ago, that gives you a lot of information about esophageal manometry and how to interpret that. But essentially, you're going to put the balloon in. Put 1 to 2 centimeters of water in air in the balloon. Confirm its position by a Bader maneuver if the patient's not breathing spontaneously, or just by an expiratory occlusion if the patient is breathing spontaneously, and that's just an expiratory hold where you want to confirm that the airway pressure and the esophageal pressure are both going in the same direction and should be roughly 1-to-1. Usually we accept an 80% agreement. And from there, then you can look and measure efforts directly. Now, what about plateau pressure or the PMI? Again, most of us were taught in medical school that the peak pressure was like this, and then the plateau pressure is like this, right? So can the plateau pressure be higher than the peak pressure? It sounds oxymoronic, but in fact, of course it can. In a spontaneously breathing patient, when they take a breath in, and then at the end of inspiration, you block the airway, their diaphragm relaxes and comes back up. You haven't let the volume change, so the same volume in a smaller container, the pressure will rise roughly to the same extent as the negative pressure they were generating when they took a breath in. And so you can see plateau pressures like this from an Images in Clinical Medicine in the White Journal. This is an okay test, I find. It doesn't, I'll do it when it's available. Not every ventilator allows you to do this still. And even when the ventilator does allow you to do a spontaneous plateau pressure like this, it depends a little bit on how good your synchrony is between the ventilator inspiratory time and the patient's inspiratory time. Sometimes you might miss a big effort because it's a short, sharp effort that the patient makes at the beginning of a breath, and then they've stopped making their effort while the ventilator is still delivering inspiration. So by the time you get to the ventilator end of inspiration, the diaphragm is already relaxed and there's nothing to capture there. So I think it's specific if you find it, but insensitive. If you don't see a big increase in plateau pressure at the end of a breath, it doesn't completely rule out that there may have been some efforts there. Right? Okay, this is the meat of this is what we actually do in every patient every day. An airway occlusion maneuver. First P.1 and then an occlusion pressure POC. Most ventilators will give you an automatic measure of P.1. Some display it continually. Some you have to press the P.1 button to make it happen. And this is the pressure, the negative pressure generated in the first 100 milliseconds of a breath, shown here. Irene Tellius has done some nice work doing some bench testing and validation showing that in most ventilators, the P.1 that's displayed on the vent is very well correlated with the same value you'd get if you brought in your own pneumotac and did a physiological experiment at the bedside. And these numbers are mostly related about effort, about drive, okay? So the P.1 tells you how much respiratory drive that they have. They're relatively independent of effort. The two things go together. This is the other thing that we do on all our patients every day, the occlusion pressure. This lets you see the ice below the water iceberg of what's happening with mechanical ventilation in patients who are breathing spontaneously. If you looked at peak pressure or at dynamic driving pressure between patients who are uncontrolled versus partially assisted, i.e. pressure support patients, you'd think that the partially assisted patients are getting less distending pressures. But in fact, their transpulmonary pressures are the same. If you don't go and physically do some maneuver, you mostly have no idea how much efforts the patients are making, whether on 5 of pressure support or 15 of pressure support. So the POC maneuver is very simple. You can do it on almost every ventilator. Sometimes it's just an expiratory hold. Sometimes it's called a NIF, a negative inspiratory force measure. But essentially, you walk in, and without telling the patient exactly what's going to happen, I just press the expiratory hold button, and this happens. Oops, the pointer still doesn't work. I'll learn eventually. This happens. Expiratory hold here, and the patient makes a significant negative deflection. This is airway pressure. Esophageal pressure, also negative deflection during the hold. You'll note that, we can use this to quantify the amount of effort, okay? You'll note that the esophageal pressure is more negative against a closed airway than during a normal breath. But what's important to notice is that the electrical activity of the diaphragm down here is unchanged. So it's not that the patient made a bigger effort when we occluded the airway. It's just that their effort generated a larger pressure because it was happening against a closed airway, which is good in the sense that we can now account for that and put in a correction factor so that we can actually measure the true amount of effort that they're making. And here's the equation here where we take so to figure out what the transpulmonary driving pressure is, or the distending pressure of the lung, you take the positive pressure that's generated by the ventilator, peak pressure minus peak. So if they're on pressure support of 10, let's say that's going to be 10. And you take 2/3 of the occlusion pressure away from that. And because you're subtracting a negative number, you're essentially adding that on. So if I go in, do a POC maneuver, and it says the POC is minus 21, and in that example, the patient, if we're on pressure support of 10, the nadir of that trough would have been minus 11 in that example, so my total POC would be minus 21. And I would take 2/3 of that, 14, and add it to the 10 of pressure support that the patient's already getting to say my estimated transpulmonary distending pressure would be 24. Make sense? So we've started at our unit, we have respiratory therapists in Canada where I work, and we've incorporated this into their usual workflow so that when they do their sort of major event rounds every 4 or 6 hours, and they're going in and charting all these things, measuring the plateau pressure, they also do a POC occlusion maneuver, and they write down the P.1 so that we can then understand, how much efforts are the patient's making, and also by looking at the P.1 and the POC together, sometimes gain some inferences about respiratory muscle weakness. As you'd expect, normally, if patients are making large efforts, they also have large drive. Occasionally, we see patients with high drive and relatively small, like numerically small, occlusion pressures. So the P.1 might be -5, and the POC is only -12. So I think that relative disconnect between somebody with high drive and not amounts of high efforts may be a signal that there's respiratory muscle weakness at play. So somebody showed these data earlier upstairs as well. So this POC measurement actually has been nicely externally validated by a different team than ours in Leo Hunks's group, and shows, while it's not perfect you shouldn't use this to say, I'm going to know exactly what my pressure time product is, or PMUS is at any given point. It's quite good if you want to know, is the effort very high? So, did I skip over a couple of options there? One other. I don't have a slide for this. One other possible way to measure effort is to use proportional assist ventilation. Does anybody like using PAV? No takers. Really? Oh. Okay, we'll see. We'll see. There's a large trial that's going to be reported at the CCR meeting in Belfast in June to see if PAV improves outcomes. But PAV essentially works by calculating work of breathing and provide every 5 milliseconds and providing support to overcome X% of that work of breathing in the next 5 milliseconds. That's how the mode works. So if you want to measure efforts, the machine's already doing it. You just have to interpret the numbers. So if you put somebody on 50% PAV, then you can look and see, 50% went from a PEEP of 5 to a peak pressure of 15. That's 10. A dynamic pressure of 10 was 50% of the work. What's the other 50%? Also 10. So that way you can also, in using that mode, you can also measure work of breathing. The machine's already measuring work of breathing, and you can tell what the work of breathing is by looking at that. When it's not actually 50%, you have to do some grade 6 algebra to figure out, 60% equals 10. What does 40% equal? But that's easily done. What do you do? So you've measured effort. Great. And if PMAS is normal, and a normal PMAS, by the way, is sort of in the 5 to 10 centimeters of water range. If it's normal and your total distending pressure is not high, great. But let's say you do this and your transpulmonary distending pressure is 30, and your POC was minus 30. You're thinking, that's really that's too high. What are you going to do about it? So you need to be there's a few things that we might do. If the level of actual inspiratory support is very low, sometimes you can actually gain by turning up the inspiratory support, and that'll make the patient relax. And if that's proportionally more than you turned up, then that might be a win. Most of these things you have to fiddle at the bedside to figure out what's going to work. Some patients respond to increases in PEEP. If you can recruit the lung a little bit, that can decrease drive. Some patients respond to increases in FiO2 actually to reduce drive. Often, if you decide, actually, I really do need to intervene, then sedation. We recommend propofol over opiates in this situation, where opiates may increase breath size and slow respiratory rate, whereas propofol will blunt the respiratory drive. And maybe there's a role for partial neuromuscular blockade, where you titrate small amounts of cisatracurium or rocuronium to induce respiratory muscle weakness, but not complete paralysis if you want to avoid diaphragm dysfunction as well. Or you could put people on ECMO. And in some cases, and and you can certainly manipulate drive using sweep gas on ECMO. This may have certainly the alveoli results. The OLIA trial results are largely due to prevention of ventilator-induced lung injury, not so much rescue from refractory hypoxemia. So this may be a role here. If you try to get patients into this sweet spot of both lung and diaphragm protection, in many cases it's hard to do if they're not on ECLS. In about 50% of patients, we were able to get patients into that sweet spot after titrating higher and lower PEEP and some sedation, but a large number still needed some additional support. So the bottom line is there's lots of competing risks here. Increased illness severity. Okay, I'm worried about lung protective ventilation, and I'm worried about ventilator-induced lung injury leading to death. I'm going to give sedation to help with that, but sedation might have significant adverse effects on delirium and inactivity and ICU-acquired weakness. And so there's lots of different, it's a complicated thing to map out. So again, this is one of the reasons that we're doing this platform trial, to try to get answers about this. And in the Drive RCT, which is comparing driving pressure targeted versus conventional tidal volume 6 mils per kilogram, plateau pressure is less than 30, we are using POC, and we're trying to maintain driving pressure to be in a normal range, both during passive ventilation, keeping driving pressures less than 15, and in spontaneous breathing, measuring POC and making sure that we're not trading overdistension caused by the patient as a cause for failure there. Okay, I've tried to tell you that the impact of spontaneous breathing in ARDS depends on the timing and the severity of illness. I hope I've convinced you that measuring patient effort is important and easy to do. And in this situation, I actually think that the data we have so far suggests that trying to normalize efforts, that may be the best way to help protect both the lung and the diaphragm, especially early in the course of illness. And with that, I will stop. Nobody interrupted me to ask any questions. I don't know if anybody has any questions now. Apologies for my hoarse voice. Giorgio.
Just a comment about the fact that today we have a deep understanding about how to measure, how to detect, but unfortunately, as you underlined at the end, our instrument, how to control excessive efforts are very limited because, well, very high PEEP, not so nice. Partial neuromuscular block, sedation, yes, finally sedation, and it's a pity.
Yeah, well, no, maybe this is another thing that we can, another target for pharmacological interventions somewhere in the future, if we can find a magic pill that decreases respiratory drive in an appropriate patient. That might be interesting. Yeah. But, yeah, I think this is, I don't know, I find it's an important clinical tool as part of your whole ventilatory care of the patient. Yeah. Yeah, so the question is if the patient, if you can reduce, by increasing PEEP, are we fooling ourselves essentially by just inhibiting the patient's ability to breathe as opposed to actually helping reduce their drive? And this is where the key is actually measuring their efforts and their drive while you do this. If you just looked at, so if you increase PEEP, like, now my lung compliant, now my respiratory system compliance from here is terrible. I have to work really hard, right? So if you were just measuring tidal volume, you might run into this problem where you've increased PEEP and the tidal volume's to come down, great. But you've overdistended everything and things are worse. If you measured my efforts just now, my tidal volume was smaller, but my efforts were much higher than they were otherwise, right? So if you increase PEEP and see overdistension, and you're on the flat part of your volume pressure curve, you're still going to see worse efforts, increased efforts, not smaller. And then you would say, oh, this is not working, I will go back down. But if you had a patient, this doesn't work in everybody obviously, but if you had a very recruitable patient who had a lot of de-recruitment and then increased their PEEP and their end expiratory lung volume increase, that's the situation where you often see a reduction in respiratory drive because you've put them on a better part of their volume pressure curve. Other questions, comments, thoughts, anecdotes? I think we're supposed to leave the room soon, I guess, but yeah.
When do you usually or not allow spontaneous breathing in terms of, I don't know, elastance or ventilatory ratio?
Yeah, so when to, I think it depends on how sick the patient is. So it's not a clockwise measurement. It's more of a severity type of measurement. So if we're really struggling with oxygenation, if the PF ratio is less than 100, then we're often in the sedation, paralysis, proning sort of arm, and there we're not breathing spontaneously. As the patient's severity of illness improves a little bit, and we're out of the proning every day window, then that's when I start thinking about transitioning the patient to a spontaneous mode. And we often use PAV or NAVA, also lots of pressure support too, but trying to maintain synchrony as much as possible. Okay, thanks very much for your attention.